Hello, my name is Linda Mullicoke, and I'm from ECMC, in case you were wondering where you were. I've been doing this for a long time, about 30-some crazy, 33 years or something like that. I'm going to make sure that she gets this. Let's send this back to Erin.
Thank you.
Erin really needs this. When we talk about driving evaluations, and when we talk about driving in general, it's a skill, and I'm just going to quickly, you guys know this better even than I do, with regards to the framework. And when we're looking at the OT framework, we're looking at the context and the environment through which a person is in, the context of the things that they have to do, okay? Everything we do has context, okay? We don't just do things willy-nilly without a reason or some kind of process behind it. Well, the same is true for looking at driving. And the occupation that we're looking at specifically is one of the IADLs, instrumental ADLs, and it's driving. What is it doing? It's moving around in one's environment, okay? That's this context that we're talking about, is how do we get, but it's a specific thing. It's not just moving like walking, all right? It's moving like community mobility. So it's a much greater or bigger thing than just walking around your home. All right, it supports independence, it has social participation, your ability to socialize and get places and be with people. Access to health services, access to things like going to the grocery store, going to your church. Those would be those social participation things. Going to meetings, if you have meetings. Going to your doctor, which is supporting your access to health services. So all these things are the things that we do that are part of your occupation in IADLs that is supported in driving. So driving has a far-reaching impact on what happens in your daily life. Every one of you, probably every one of you, came here in a car, right? Did anyone come by bus? It would have been goofy from the school, I would say that. You'd have to take the Bailey, and it gets kind of, it gets a little weird. To get here, you'd have to go by way of, Poughkeepsie to get here. Even though we were literally, 10 minutes on a bad day to get here. So all of you had to get here in some conveyance. Either you took a ride with a friend, but in any way you got here as a car, and since we don't have any Ubers yet, somebody had to drive you. And recently Uber pulled their driverless vehicles, or autonomous vehicles as they call them, because of the crash in California, I believe it was. So apparently there's some issues about what happened. Okay, so that's sort of the context. I'm not going to go into that. That's something that you guys understand, the framework. I'm not really getting into that, but I just wanted to kind of give you a position as an occupational therapist as to why driving is important and why you, as an occupational therapist to me, why would you want to know about it? And why is it important for you to think about it all the time, even when you're seeing patients in a variety of settings, okay? Now, it may not be the first thing to see when you maybe are seeing them in the ICU, but it is certainly something that you should be starting to consider and think about if you see them and they're in subacute, or they're in the hospital and they're ready to get discharged, or they're in the in the rehab unit, and you're looking at what's going to happen, or you're an occupational therapist in an outpatient setting, and this person comes in and they want to know. Like, I have a patient right now who's dying to drive, who had a head injury, and he's like, "You're the woman, right?" I'm like, "I don't know what woman." But he found out I was the one that does them. So he's like, "Yeah, okay, what is that?" And he's like, "Hold your horses." The doc makes a decision on that. But nonetheless, it is an important thing. It is the most adult ADL you're ever going to do. Hi. It's the most adult ADL you're ever going to do. Okay? By the time you were like 5 or 6, you could pretty much do everything. You could wash yourself and dress yourself, and maybe not really well, but you could do those things. You could get yourself washed, dressed, all that stuff. You could probably make, peanut butter sandwich or something like that. But the thing that defines you as an adult is your license, especially in this particularly in this country. So then it really has a value that you wouldn't believe, okay? It's extremely important, and because we don't have really great public transportation, and I'll talk about that later, it becomes sometimes even more important. So what are the driver evaluations? It's testing a patient in clinic, in our case, in an in-clinic, and an in-vehicle situation, or behind the wheel, if you want to call it that. A variety of tests are used to determine physical and cognitive abilities, okay? We need to look at more than just that. Now, in those cases, this is maybe someone who had a big problem. Maybe they had a head injury, or they had a spinal cord injury, or they had a stroke. Usually it's a fairly big event, or they're older and they're getting a little more forgetful, and maybe they've had a couple of maybe lost, I got lost situations. Like I went for the milk and ended up in Jamestown. Kind of. All right. Well, you laugh, it's happened. Or the gentleman a few years back who apparently he wanted to go to see his daughter. I don't even know where it was, but he left Buffalo, went towards Grand Island, but apparently was not supposed to be going in that direction. They turned him around, and he literally kept going and ended up in Tennessee. So it does happen. Okay. What did the MD say about driving? Not much. A lot of your doctors, especially around here though, have a much better understanding of driving and driving issues. Driving issues have become much more important particularly for your PMDs, your primary docs, because they're seeing an increasingly larger, older population, particularly in Erie County. Erie County is one of the oldest, I'll get to that, counties in the entire United States. And so it's not uncommon that they're going to have to do that. So it's not uncommon here for physicians to have a understanding, at least a brief working understanding of the job that we do here. All right, but say for instance, this is stroke patients. This is an old study, but it does talk about the fact that there's really not an awful lot that's talked about, even for folks who have strokes, as to whether or not they're looking at their driving at all. And you can see that very small portion of them actually end up getting a driving evaluation at all. So it's sometimes they don't talk about it at all. I think that that's changing. I think as you see physicians realizing how important, and the fact that there is such an aging population, and this has become a topic of conversation, in the media. Okay, the media has taken it up for various reasons, for people getting lost, like I just described, or for people doing drive-throughs in places that aren't drive-throughs. Carrabba's had a guy drive into it. Of course, Cheeseburger actually had a death as a result of it. Multiple fast food places, including McDonald's in Jamestown, a Burger King in Dunkirk, and another Burger King up in this area. I can't recall exactly where. So it happens all the time. All right. Though saying that, though, means that it is an important issue that everyone needs to take a piece of, okay? And as occupational therapists, you're actually in a great position to at least, if nothing else, determine whether they need to do more than just have the doc say it's okay, or should they go on and see someone like myself, who is a specialist in looking at driving specifically. By 2020, 1 in 5 drivers will be 65 or older. That's a load full of old folks, okay? I will be almost there. No, I won't be there quite, but I will be almost 65, okay? So because I'll almost be 65, I really don't want to look at this. This is an old slide too, but it's actually accurate, okay? This very amount of people are exactly the folks that are going to be driving. And let me tell you, I will just be horrible on driving. No. A lot of the things actually that are coming out, I'm very interested to see how they will have an effect. And since I can be my own test subject, it'll be great. I want to apologize at the get-go. I do have a cold, so my voice will sometimes give out. All right. No group of teenagers has more accidents or a higher fatality rate per mile driven. Important to talk about that, and I want to mention it really quickly for you because per mile driven really makes a difference, okay? Because a lot of times people say, oh, I don't drive that far. Well, it really doesn't matter how far you drive because this is looking at per mile driven, okay? So, although teenagers up to the age of like 20-ish are your worst drivers in general as a class, you can see this little uptick, all right? Now recently, this study was redone. So they redid this study, almost exactly the way it's done now. It was redone, and people said, oh, they're doing better. The people are doing better. There's less per mile driven crashes for older people. That's only half the story because they didn't look at the whole thing. The shape of the curve is exactly the same, it's just slightly lower. But it's lower for everybody. Lower for teenagers, lower for folks who already do fairly well, which would be those 40 and 50 people. It's great. So it's good for everyone, and there's probably a lot of reasons that might go into talking about that. Something that the people who did this study didn't really look at, but probably things that we could say are some of the things that you're seeing right now. Like for instance, I just saw the new Corolla is coming out with lane assist and automatic braking, or whatever the heck they call that when, so they don't run into the back end of somebody. Well, those are really great things. Those also don't tend to be the things, but the lane assist, yes. The running into the back end of people is generally not what you see with older folks. So in general, that is that. Usually running into the back end of someone these days really means texting. Okay, so that's usually what that is. Crash by age remains the same. This is like the new one, okay? So basically it's still the same. The data has remained the same in subsequent studies. So they've done the same studies over and over. The shape of the curve is still the same. So it still says that younger people are still poorer drivers. Older people are a little better than younger people, but not by much because they're showing an uptick in the number of crashes per mile driven. Also, I might add, the fatality rate for older folks is more. Why? Why do you think that is? Fatality, like you die.
They're frail.
Yeah.
Frailer.
Absolutely. Yeah. They come with a lot more comorbidities than you would expect with, like, say, an 18-year-old. Okay? So, what an 18-year-old can survive will pretty much not in somebody who's 80. So you're absolutely right. So they are frailer. They have more problems. So they tend to be not so hot with, with surviving crashes. All right, this is a crummy slide. I still have to fix it. I don't know why I haven't. Basically, New York is like number 10 there, okay? We have like this huge number of like these things. Keeping baby boomers mobile, preserving the mobility and safety of older Americans. And that would be the baby boomers, and I am part of the baby boomers. So you need to keep me safe. So New York is 10th in the nation in folks that are older. Oh, I already said that, and why this is there you go. So we're 10th in the nation. We tend to be folks that are older. Erie County in general tends to be older than, say, downstate, okay? And when I say downstate, I mean I'm talking about New York City area. It's definitely older. As a result, we tend to have more problems with older drivers, okay? We do. Okay, why would you need a driving evaluation? Now this is where a new occupational therapist should think about this. You want to determine fitness to return to driving after an illness or an injury. You want to determine their fitness to begin driver training in the case of somebody who's young and who is a disability, and determining whether or not they should even begin driver training. But as an occupational therapist, there are some things that you can do in your practice as a generalist to be able to at least determine whether or not a person needs an actual driving evaluation from someone like myself, or are they really doing really well and they really don't need to do that. Now in the case of someone who has a disability and has never driven, more than likely this would be a place where they would go to make that determination. But, you know, certainly when you're talking about returning after an illness or injury, it would be something that as an occupational therapist, you could certainly determine whether or not they're having enough issues that you might want them to have a little deeper look into their driving fitness. All right. So there's two parts of our evaluation, as there is in anyone who does driving rehabilitation. And the first one is an in-clinic evaluation. And that's where we do formal and standardized tests to determine how well a person can function cognitively, physically, that type of thing, and visually, all right, in the clinic. The second thing is the in-vehicle or behind-the-wheel evaluation. And in that case, we're actually taking them out in a vehicle that has a brake on our side, so it's like a driver-ed vehicle, to determine whether or not they can drive. I do not use, nor have I ever used, a simulator. There has been no really great data to suggest that utilizing a simulator actually gives better or more concrete data regarding the person's ability to resume driving. And there's a lot of data that indicates some people can't even do it because they get sick. All right. In fact, did you ever talk to Lisa about it? Okay. But some people can't even get into the simulator because it makes them ill. They get kind of like almost like like sick, you know, like car sick, because of the movement that happens as a result of the bizarre video things. But there isn't any, there's really not any really great data that says that, despite the fact there have been a number of studies that have tried to do this. Now, you could say that they haven't come up with a really good simulator, which I probably could agree with, but I'm still not positive that that would be enough, okay? I would certainly tell you that patients don't agree with that. They would be like, yeah, but it's not a car. As it is, I get, yeah, but it's not my car. So, we do that. So the in-clinic evaluation involves a number of parts. And I love how I just wrote patient interview. Like it was really quick and easy. So if anyone doesn't know, but Erin is actually, has helped us put together, and we are still working on, an electronic version of our driving evaluation. And it is breaking the Allscripts vehicle that we're using to do it, because it is extremely hard. And you know, when they talk about how difficult it is to describe occupational therapy to some extent, and then to talk about the numerous things and areas that we look at, it is daunting. And it isn't until you sit down, right, and actually put it together that you're like, oh my God, this just goes on and on and on and on, right?
Yep.
Forever. And I love how I just wrote patient interview, like that's it. It isn't. It's probably the most important part of our evaluation is to interview the patient. And we interview the patient for a variety of things. Everything from, you know, problems that they have, you know, like they've got high blood pressure, diabetes, or blah, 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 to, you know, so past medical history, their medications, why are they here, their ADLs, can you dress yourself, does somebody have to help you, does somebody have to help you for some of those executive functions such as your medication regimen, or because of your, you know, do you pay the bills, or has someone had to help you to do that, to what do you do when you drive, where do you go, what kind of roads are you on, okay, you're telling me you don't really drive very, you know, that you're always off the expressway and not really busy streets, but you're telling me you go on transit. What? You know, those kind of things. So you want to get, we get a lot of information that has to do with all sorts of things, okay? Why is someone here? We might get their crash history, or their, do you get lost when you know, do you have that? And very often the patient's sitting there going, no, no, and the family member that sits right behind them is going like this, yes, yes, because, you know, yes, they are doing it. Maybe there are some problems. So sometimes we're looking at interviewing not just the patient, but the person who came with them. We do recommend that someone comes with everyone for a lot of reasons, but it's really great to have the family in, not the whole family, just the person, because it's a little bitty room. But it's important to have someone from the family or someone who's going to represent the family, because it's important for them to see how that person is doing in the in-clinic portion of the evaluation. They sometimes are surprised, okay? You know, these days when sometimes some of you folks maybe not from this area, and maybe your parents are still back in whatever area you're from, well, that sometimes happens. You know, my daughter now lives in Pittsburgh because I wanted her not to be there. But you can't keep them home. The problem is that becomes difficult when you leave an elderly parent and you do go to these other places, because sometimes you don't have a good handle on how that elderly parent is actually doing. So for some folks, when we do this patient interview, and then when we do some of the other things that we do, it is eye-opening. Sometimes tragically eye-opening for these folks. So it can be quite difficult for them. Okay, so the patient interview, as I said, is quite big. Okay, I didn't even scratch the surface. It's kind of most of the things that are probably important, but those are things. The motor system, we look at the motor system. Those things are simple. It's the range of motion, your strength, your coordination, how well they can do that. So we might be looking at finger to nose test, or we might be looking at how their grip is. I'm not going to usually take a dynamometer and check their grip. I'm just going to, you know, just have them squeeze my hand, that kind of thing. So I'm doing somewhat of an informal testing of that. Range of motion, same thing, looking at, can they get their arms up? They don't need to have 180 degrees of shoulder flexion to be able to drive. But they do need to be able to get their arms up reliably on the steering wheel and not be doing this or shuffling the wheel, because that's really not going to be great. All right. We also look at things like sensation. If they can't feel their foot because they're diabetic, that can be quite problematic for them to get their foot from the gas to the brake. Because if you can't really feel your foot moving from the gas to the brake, you could either be hitting the gas and the brake at the same time, or hitting the gas thinking it's the brake, which has happened in the past. Probably the reason why drive-thrus now have extra drive-thrus, because of that. So sensation can be quite important, and we do look at that. Reaction time testing, you'll actually see what we use for that, where we actually look at brake reaction time, the ability for the person to move their foot from the gas to the brake to a stimulus red light, okay? You would be surprised, however, because there's also a green light, how it tends to give us information beyond what the folks originally intended for this piece of equipment. And when we use it later, you will see that that's why. We look at visual skills, but we're not just looking at straight ahead acuity. Usable vision has got to be at least 20/40, at least in the state of New York. And that's pretty much for most states. There are some differences. 20/40 is pretty much accepted as the low normal of acuity. However, different states will look at folks who are less than 20/40, but under certain circumstances. And so you need to look at your state to determine under what circumstances. So sometimes some places will allow a thing called bioptics, and I'm not going to get into that other than to say that that exists, and that some states allow it and others do not. In New York, it is allowed, okay? In many states it is, but not all states. So we have to remember too that in general, driving is a legal thing as well as something that somebody does as part of their occupation as a human being here, as an adult. But it also means that there are certain recommendations, or certain standards that are determined by the states in terms of how things are done. So we have a machine that we're going to look at. Fusion is obviously your ability to use your eyes together. Depth perception is your ability to judge how close or how far away something is. Color vision, important. Contrast vision that I don't have up there but is actually very important is your ability to see shades on shades of something, which is extremely important when we're talking about night vision, which I also don't seem to have up there. But peripheral vision, a minimum of 60 or 70 degrees, actually should have 140 degrees cumulatively. I will say 60 is probably the minimum in one eye, so you would expect more in the other. And if you don't have that, then you should be concerned. Less than 60 in either eye really suggests some kind of issue. It could be glaucoma, something like that. It could be that they have a homonymous hemianopsia as a result of their stroke. So those are certainly that, and I will talk about that problem in a little bit. Visual perception, we've used the motor-free, we use specific visual perception tests, and the one that we use most frequently is the MVPT, motor-free visual perception test, but the visual closure portion, because it has been shown through studies to be somewhat indicative of driving performance. It is not 100%, and as Aaron found out, there's a lot of all sorts of goofy things that people use, and some are more predictive than others for that. Okay, so that's for visual perception. Obviously, their ability to see these things is important. We also look at their cognition, their thinking skills. As I mentioned, we do already have that information that we've kind of gleaned from our interview about how that person's effectively working at home. How are they getting along? How are they doing things? Are they able to plan meals? Do they do their meals? Do they have to have somebody make it for them and then all they do is reheat? That's what I'm telling you, the interview is pretty big. Are we having someone do Meals on Wheels? Or are we, is that person, they'll tell me, oh yeah, I do my own bills, and then you find out, well, no, not really. All their bills are automatic now, So they're doing nothing but taking money out occasionally and have no idea, and don't even put it in their little checkbook, so nobody knows what they have, that kind of thing. But we are looking at things like in cognition, we're looking at, their general abilities. We happen to use the mini mental status examination, not because I consider it a really great test,